We'll discuss here pediatric rheumatology. Check all the updated information in the third edition 2024-2025.
Juvenile idiopathic arthritis. Previous name is juvenile rheumatoid arthritis. Idiopathic because we don't know the exact cause. It is defined as arthritis of one or more joints occurring at least 6 weeks. Chronicity is the key for the diagnosis. There is no certain lab to confirm the diagnosis of juvenile idiopathic arthritis. It is a diagnosis of exclusion. Again, very important to know that juvenile idiopathic arthritis, the diagnosis is made by chronicity, at least 6 weeks in a child less than 16 years of age. Painful joint, inflammation of joint. The most important sign is limited range of motion, chronicity at least 6 weeks. Again, there is no single lab to prove or confirm the diagnosis. It is a diagnosis of exclusion plus chronicity. Detailed history and physical examination will help you to narrow your differential and to be able to order the appropriate lab to rule out other diseases. I will give you a few examples here, like reactive diseases, for example, post-streptococcal infection, rheumatic fever. Other inflammatory conditions like inflammatory bowel diseases can be associated with arthritis, sarcoidosis, infection like septic joint, osteomyelitis, post-infectious toxic synovitis, very common. Systemic diseases like lupus, Henoch-Schönlein Purpura, malignancy like leukemia, osteosarcoma, Ewing sarcoma, and trauma. Classification of juvenile idiopathic arthritis. Oligoarticular means 4 or less joints. Polyarticular means 5 or more joints. Systemic onset juvenile idiopathic arthritis means high fever, high spiking fever persistent for at least 2 weeks, plus arthritis. This will make the diagnosis of systemic JIA is very likely. If oligoarticular or polyarticular associated with positive ANA, this will increase the risk of iritis, uveitis, or iridocyclitis. So these patients, they need a close follow-up with ophthalmologist and slit lamp examination. Very common that juvenile idiopathic arthritis, they have negative RF. So RF is not helpful in the diagnosis of JIA. So if it's positive, this just will give you a hint that this patient is likely to continue to have or there is a risk for this patient to continue to have rheumatoid arthritis during adulthood. This is a classic presentation of juvenile idiopathic arthritis. The joint is painful, tender, warm, swollen. The pain worse in the morning, can be associated with lymph. The symptom has to be persistent for 6 weeks, and you have to rule out all possible causes of arthritis before you make the diagnosis of juvenile idiopathic arthritis. Systemic JIA is arthritis associated with fatigue, anemia, fever. The fever usually greater than 39 Celsius. The fever comes once or twice a day, associated with a salmon-colored macular rash, usually non-pruritic, so the rash comes and goes with the fever. Hepatosplenomegaly, lymphadenopathy, pulmonary like interstitial fibrosis, pericarditis, leukocytosis, thrombocytosis, elevated ESR and CRP, and serum ferritin. ANA is usually negative. Diagnosis of juvenile idiopathic arthritis is a clinical diagnosis. There is no diagnostic test for JIA. Other causes of arthritis must be excluded carefully before the diagnosis is made. Very important to know, if you order rheumatoid factor, is usually negative in cases of JIA, so is not helpful in the diagnosis. ESR and CRP, very important to know. In cases of oligoarticular, usually they are normal, so do not make this a distracting factor for you to rule out the diagnosis. Usually they are normal, ESR and CRP in oligoarticular JIA. In polyarticular, they may be mildly elevated. They are more elevated in cases of systemic JIA. Very important to know. Screening eye examination for uveitis or iridocyclitis in cases of JIA. If it's systemic, is every 12 months because the risk is low. If it's oligo or poly JIA, is every 6 months, except if it's oligo or poly JIA and less than 7 years of age and positive ANA, it has to be every 3 to 4 months because the risk is the highest. Treatment of juvenile idiopathic arthritis. Mild arthritis, simply you can give non-steroidal anti-inflammatory drugs, for example ibuprofen. For disease limited to one joint, you can use intra-articular corticosteroid injections to save the patient the side effect of oral steroids. Systemic JIA is usually treated with oral or intravenous corticosteroids. For children who have more aggressive arthritis, They are usually treated with disease-modifying agents, for example, methotrexate, and this can be given once a week. Psoriatic arthritis is arthritis in small and large joints. If the patient is having psoriatic rash, this will make the diagnosis very easy. But if there is no rash, you have to take detailed history, including family history of psoriasis in a first-degree relative, and detailed physical examination, including the nail. Any patient in general with arthritis, you have to examine the nail. Nail pitting will make the diagnosis of psoriatic arthritis very likely. This can be associated with dactylitis as well. There is a risk of uveitis, so we have to do slit lamp examination every 6 months. This patient, they may have also positive ANA. Also, they may have positive HLA-B27, especially if they have inflammation of axial skeleton or inflammation of sacroiliac joint. Enthesitis-related arthritis means inflammation of tendon insertion into bone. Usually affect older children more than 8 years of age, commonly affect the sacroiliac joint. These patients, they may present with pain, stiffness, and loss of mobility of the lower back. Can present also with arthritis in the lower extremities. Usually they have positive HLA-B27, and also you can find a positive family history of HLA-B27 related diseases like psoriasis, ankylosing spondylitis, inflammatory bowel diseases. Systemic lupus erythematosus, the diagnosis can be difficult and challenging because not all the patient will present with malar rash and arthritis. So sometimes it takes 1 month to 3 years from the onset of symptom for the diagnosis to be made because of non-specific presentation like fever, weight loss, lymphadenopathy, hepatosplenomegaly. So the message here, if you have a patient presenting with non-specific symptoms and you cannot make sense of the combination of these symptoms, the best thing to order is ANA because this can make the diagnosis of systemic lupus erythematosus faster. Any organ can be affected by systemic lupus erythematosus. The most classic presentation is malar rash, which is erythematous raised rash in the face, sparing the nasolabial fold, giving the appearance of butterfly. Photosensitivity rash in reaction to sunlight. Oral ulcers are usually painless. Arthritis is non-erosive, and this will make the diagnosis easier and faster, especially if it's combined with rash. Psoriasis like chest pain, pleuritis, pericardial effusion, pleural effusion. Renal disorder like persistent proteinuria, nephrotic syndrome, or lupus nephritis, and this is the most common cause of morbidity and mortality in patients with systemic lupus. Neurologic disorder like seizures, psychosis, hematologic disorder like anemia, leukopenia, lymphopenia, immunologic disorders, positive anti-double-strand DNA, positive anti-Smith antibodies. ANA is positive in 99% of the cases of systemic lupus. Negative ANA makes the diagnosis of systemic lupus very unlikely. What are the labs to order for a patient with suspected systemic lupus erythematosus? CBC to look for potential cytopenias, anemia, lymphopenia, leukopenia. Comprehensive metabolic panel for electrolyte abnormalities, elevated transaminases, elevated BUN and creatinine. ANA is positive in 99% of the cases of systemic lupus. So if you have a patient with suspected lupus and ANA came back negative, this makes the diagnosis of systemic lupus extremely unlikely. Very important to know that 1/3 of healthy population, they have positive ANA. So if you have a patient with positive ANA and is asymptomatic, there is no further action to take because this can be normal. Anti-double-strand DNA is positive in 75% of the cases of systemic lupus and is an important test to order at the time of diagnosis and also used to monitor disease activity. C3 and C4, they are low or undetectable in cases of systemic lupus during a flare or during disease activity. So anti-double-strand DNA, C3 and C4, they are very important tests to monitor disease activity and the flare. Anti-Smith antibodies, they are positive in 50% of the cases of systemic lupus. They are highly specific for systemic lupus erythematosus, but is not a good test to order to monitor activity because it may remain elevated. Neonatal lupus erythematosus is because of transplacental passage of SSA or SSB from the mother to the fetus. These antibodies can cause destruction of the conductive system of the heart, and the earliest manifestation during pregnancy is fetal bradycardia. And once the fetal bradycardia is detected, the mother typically will receive dexamethasone to prevent further destruction of the conductive system of the heart. 30% of the infant born to a mother with systemic lupus, they will develop congenital heart block. And 30 to 50% of these infants with congenital heart block will require pacemaker. After birth, the infant may develop rash or other manifestations of systemic lupus, but all these symptoms will resolve 6 months later except heart block. Management of systemic lupus erythematosus is usually multidisciplinary team, including pediatric rheumatologist, pediatrician, ophthalmologist, nephrologist, social workers. Classic medications used for systemic lupus: hydroxychloroquine, corticosteroids, especially during flare, cyclophosphamide, especially lupus nephritis, other immunosuppressive agents, non-steroidal anti-inflammatory drugs, calcium and vitamin D. The role of pediatrician here is very important to monitor for hypertension, progression of renal disease, or monitor for proteinuria, no live vaccines if immunosuppressed, school accommodation, diet, and vitamins, especially if the patient taking corticosteroids, no salt added. This is very important to know. Ankylosing spondylitis and spondyloarthropathy is inflammation of sacroiliac joints and the axial spine. The classic presentation: low back pain, worse in the morning and improve with exercise. Labs: high ESR and CRP, and usually correlates with disease activity. Positive HLA-B27 in most of the cases. You do not need to order this test to screen for this disease. It may help to support the diagnosis, but is not required to make the diagnosis of ankylosing spondylitis. Radiologic finding: you will see inflammation at the sacroiliac joint and the classic bamboo sign. The treatment here: non-steroidal anti-inflammatory drugs. It may help to decrease the pain and inflammation. Sjögren syndrome commonly presents in pediatrics with recurrent parotitis. In adults, dry eye or keratoconjunctivitis sicca. Serology: elevated SSA and SSB. The management for dry eye: artificial tears, pilocarpine tablets, anti-malaria for skin rash and arthritis, commonly associated with systemic lupus, and there is a risk of lymphoma. Reactive arthritis means inflammation of joints in reaction to past infections, for example, GI infections like Shigella, Salmonella, Yersinia, Campylobacter, or even C. diff. Genitourinary tract infections also can be associated with reactive arthritis. 2 to 4 weeks later, the patient will develop arthritis, typically in the lower extremity or weight-bearing joints. If it's more than one joint, this will make it easy to make the diagnosis faster. Non-infectious urethritis, arthritis, conjunctivitis, these are the typical triads. And if you do lab, typically the ESR and CRP, they will be elevated. HLA-B27 is positive in 65 to 96% of the cases, is helpful to support the diagnosis, but is not required to make the diagnosis of reactive arthritis, so is not used as a screening test for reactive arthritis. Treatment is supportive and usually is self-limited and will go away with time. Juvenile Dermatomyositis, from the name, is inflammation of the skin and muscle. The presentation, or the classic presentation: muscle pain and weakness. Skin rash, which is exacerbated in sun exposure or photosensitivity. Gutron papules, which is elevated shiny violaceous papules over the bony prominence, for example, knuckles. Heliotrope rash is purple or dusky rash around the eyes or in the periorbital area. Calcinosis cutis, which is firm nodules, white or flesh colored over the bony prominence. Diagnosis is made by detection of elevated creatine kinase level. Treatment is prednisone, sun avoidance, and hydroxychloroquine for rash. Systemic scleroderma or systemic sclerosis is because of excessive collagen deposition in skin and internal organs, commonly associated with pruritic skin, Raynaud's phenomena, which is a whitening of digits or fingers on cold exposure. This can be associated with pain, cyanosis, and also followed by hyperemia. Difficult swallowing or esophageal dysmotility, shortness of breath and chest pain, joint pain and limitation of movement and muscle weakness, commonly involve lung and can cause interstitial fibrosis or sclerosis, affects the kidney as well. In 2/3 of the cases can be associated with positive SCL70 topoisomerase antibodies. Localized scleroderma, or well known also as linear scleroderma or morphea, this is the most common form of scleroderma in pediatrics. The classic presentation is a streak, or well known as in Codicebur, which is a double stroke from a sword. This is the meaning how it will look like, which is a depression in the bone in the face and can cause facial asymmetry and facial deformity. This can be deep enough to cause a seizure, also can be associated with uveitis. The treatment is mainly supportive. physical therapy if joints are involved. Typically, all labs are normal in cases of localized scleroderma. Prognosis resolves spontaneously within 3 to 4 years. Behcet's disease is a rare disorder, affects any size blood vessels in the body, can be associated with inflammation anywhere in the body. Criteria for diagnosis of Behcet's disease: recurrent oral ulcers 3 times over 1 year, plus at least 2 of the following: recurrent genital ulceration, eye inflammation, characteristic skin lesions, a positive pathology test. What is pathology test? When you strike the skin with a needle, you wait 48 hours. If the skin develops papule or pustules surrounded by skin erythema, this is considered positive pathology test. There is no specific lab to confirm the diagnosis of this disease. It is a clinical diagnosis based on these criteria. Treatment is azathioprine or infliximab can be used. Henoch-Schönlein Purpura is the most common vasculitis in children. It is a small blood vessel vasculitis mediated by IgA antibodies. The classic presentation: purpura, which is 95 to 100% of the cases affects the extremities, especially the buttock and lower extremities. Arthritis or inflammation of joint, arthralgia. GI symptoms: abdominal pain, nausea, vomiting, GI bleeding, intussusception, nephritis, proteinuria, hematuria, hypertension, subcutaneous edema, and scrotal edema. Diagnosis of Henoch-Schönlein Purpura is a clinical diagnosis. There is no certain lab to confirm or to help in the diagnosis of Henoch-Schönlein Purpura. So it is a clinical diagnosis. Very important to know, this is a very differentiating point. Platelet count in Henoch-Schönlein Purpura may be normal or elevated. Normal or elevated, but if it's low, this will suggest a different diagnosis like thrombocytopenic purpura. Occult blood may be positive because of GI bleed. ESR can be variably elevated. You need to screen for blood in urine and protein in urine. Very important. This is the message I would like to give in this slide. Any patient diagnosed with Henoch-Schönlein Purpura has to be monitored for at least 6 months to monitor the urine for protein and blood, and to monitor the blood pressure for hypertension. And you need to repeat the test over 6 months, even if the initial lab for urine was normal. Treatment of Henoch-Schönlein Purpura is supportive, reassurance, discontinue any causative drugs, for example ampicillin, hydration, non-steroidal anti-inflammatory drugs for joint pain and swelling. Corticosteroid use is controversial, however can be considered in cases like persistent nephrotic syndrome, severe abdominal pain, severe scrotal edema, neurologic system involvement, immunosuppressive in complicated cases. Kawasaki disease is simply vasculitis, affects small and medium-sized arteries, especially coronary arteries. The most common cause of death is myocardial infarction. The exact cause remains unclear. Diagnostic criteria for Kawasaki disease: fever lasting longer than 5 days, longer than 5 days, plus 4 of the 5 following main clinical features. Number 1, changes in the peripheral extremities, mean redness, edema of hands and feet, followed by desquamation of the skin. Number 2, polymorphous rash. This rash can be seen anywhere in the body, but mainly or commonly seen in the groin area and extremities. Oropharyngeal changes like dryness, fissuring of lips, strawberry tongue, erythema of the pharynx. Bilateral non-oxidative painless bulbar conjunctival injection means redness of both eyes with no discharge. Acute non-purulent cervical lymphadenopathy, simply large lymph node in the cervical area larger than 1.5 cm and usually unilateral. If any patient meet this criteria, the diagnosis of Kawasaki disease is confirmed. There is no single lab to confirm the diagnosis, so it is diagnosed clinically. Common associated symptoms with Kawasaki disease, very important to know: high drops of gallbladder, diarrhea, vomiting, or abdominal pain in 61% of the cases. Irritability, most of the infants and young children with Kawasaki disease, they are irritable, they are not happy. Vomiting alone, cough or rhinorrhea, decreased oral intake, weakness, or joint pain. As soon as the patient diagnosed with Kawasaki disease, echo has to be performed at the time of the diagnosis. Then we have to repeat the echo again in the second week of illness. Then again 1 month after all lab results have normalized. For example, if the ESR went down to normal, you need to repeat the echo 4 weeks from this time. Then again in 1 year, If the echo at 8 weeks is normal, refer to a pediatric cardiologist at any time if the echo is abnormal. As you see here, there is a coronary aneurysm and there is a clot in the middle. This is what your goal to prevent. Very important to know also, echo is a very important diagnostic tool in cases of atypical Kawasaki. Very important to know, no specific laboratory test is used to diagnose Kawasaki disease. These labs are suggestive. These labs are helpful in cases of atypical Kawasaki. For example, if you have a patient with atypical symptoms of Kawasaki like fever for 5 days and just two additional criteria or 3, and you are not sure about the diagnosis of Kawasaki disease, these labs may be very helpful. For example, if you have the CRP and ESR, they are normal and the echo is normal, this makes the diagnosis of Kawasaki disease in this case unlikely. Labs suggesting Kawasaki disease: CRP more than or equal 3, ESR more than or equal 40, white blood cell count or leukocytosis more than or equal 15,000, normocytic normochromic anemia for age, sterile pyuria. This is best to be obtained by clean catch because it is a mucositis in the urethra. So if you do it by cath, you may miss the white blood cell in the urine. So if it's more than or equal 10 white blood cells in the urine is suggestive. Serum ELT is elevated more than 50. Low serum albumin less than or equal 3. On the second week of illness, platelet count will be elevated. The average is 700,000. Sometimes it goes up to 1 or 2 millions. Classic treatment of Kawasaki disease: intravenous immunoglobulin or IVIG and aspirin. Why we give IVIG? Because it relieves acute inflammation, decreases the risk of coronary aneurysm. The maximum benefit to be given within first 10 days of illness, average 5 to 7 days of illness. IVIG, the dose is 2 grams per kilo as a single infusion over 12 to 14 hours. If the patient develops rash during infusion, you can slow down the infusion rate and give Benadryl. Watch for anaphylaxis or aseptic meningitis. Aspirin, because it has antipyretic effect, anti-inflammatory, and also has a synergistic effect with IVIG plus antiplatelet activity. You start with high dose, 80 to 100 milligram per kilo per day until the fever resolves. Wait 48 to 72 hours. If the fever doesn't come back, you discharge the patient on oral aspirin, 3 to 5 milligram per kilo per day. For how long? For 6 to 8 weeks. And if there is no cardiac involvement in repeat echo, you are able to stop the aspirin afterward. Why we give the low dose after discharge? Because it has antiplatelet activity. What happens if the patient develops aneurysm? This patient has to continue an aspirin. What if the aneurysm doesn't resolve? You have to continue forever. Very important to know, if the patient resistant to IVIG, there are other medications you can give, for example, corticosteroids. Growing pain, very important to discuss because it can be misleading. It's a diagnosis of exclusion. It is believed to be a type of stress injury. Otherwise, the exact cause is unknown. Preschool or school age, this is the most typical age, 3 to 10 years of age. Bilateral extremity pain, always bilateral, moving from one leg to another, is not localized, is not just in one single location. Intermittent pain comes and goes, so is not persistent. Pain occurring during the evening, mostly at night. Pain may awaken the child from sleep and resolve by the morning. Does not limit activity during the day. If it limits activity during the day, is not a growing pain. Occurs after days of significant activity, most commonly affect the knee and the lower extremities. In cases of growing pain, physical examination is absolutely normal. If the patient is having fever, weight loss, hepatosplenomegaly, rash, limp, joint swelling, localized pain in certain location all the time, this is not growing pain. Persistent all the time, day and night, this is not a growing pain. You have to look for other causes. If any concern for another potential diagnosis, the best initial investigations are radiographs, complete blood count with differential, ESR, and CRP. The treatment reassurance: no investigation whatsoever in typical presentation, ice, heat, massage, non-steroidal anti-inflammatory medications. Reflex sympathetic dystrophy, it's a chronic pain syndrome. The exact cause is unknown. Pain affect one or more limb, often result or the triggers are trauma, venipuncture, stress, or surgery. Limb becomes swollen, red, mottled, warm, cold, sweaty, or hyperhidrosis, which is asympathetic reflex. Pain is out of proportion of touch, which is well known as hyperalgesia. Diagnosis is a clinical diagnosis. Because of disuse of the affected area, the bone in the affected area may show demineralization on X-ray, less uptake on bone scan. Treatment is aggressive physical therapy and symptomatic. Gabapentin or amitriptyline may help. Periodic fever. Familial Mediterranean fever. It's a genetic disorder transmitted as autosomal recessive associated with periodic fever. Fever comes in cycle every 3 to 5 days, every month, several times per year. The fever is predictable. Can be associated with severe abdominal pain, pleuritis, pericarditis, or chest pain. Scrotal swelling can be severe enough to mimic testicular torsion. Can be associated with rash, arthritis, arthralgia, myalgia, joint pain, or muscle pain. The key points here for the diagnosis of familial Mediterranean fever: periodic fever and pain anywhere in the body. Plus or minus positive family history. Of course, a positive family history will make it easy to make the diagnosis earlier. Most important complication of familial Mediterranean fever is amyloidosis. This can cause proteinuria and renal failure. Diagnosis is a clinical diagnosis. It can be supported but not excluded by genetic testing. So means negative genetic testing does not exclude or does not rule out the diagnosis of familial Mediterranean fever. ESR and CRP and white blood cells usually elevated during the attack. Treatment, the main treatment is colchicine. So the most important aspect in the management of familial Mediterranean fever, the correct diagnosis and the institution of therapy early. Very important to monitor the patient for development of complication and follow up every 3 to 6 months and monitor colchicine toxicity. This is a very interesting disease. The name itself explains the disease: periodic fever, aphthysis stomatitis, pharyngitis, and cervical adenitis, PFAPA. It's a benign syndrome, the most common age of presentation between 6 months and 7 years. The main is 3 years. The periodic fever usually lasts from 5 to 7 days. Periodicity is usually less than 4 weeks. Usually there is no signs of infection, so if you do throat culture, usually negative. Children in a good health between episodes. Fever cycles usually stops by teenage years. It's a clinical diagnosis. There is no specific test to confirm the diagnosis of this illness, so it's a clinical diagnosis. Treatment is non-steroidal anti-inflammatory drugs. Actually, a single dose of steroid like prednisolone or prednisone can dramatically shorten the illness and even end the episode. Tonsillectomy if the patient requiring multiple doses of steroids per month. Summary and practice cases. This is a 4-year-old boy presents to your office with a 6-day history of fever, bilateral conjunctivitis, red and fissured lips, strawberry tongue, swelling in both hands and feet, unilateral cervical lymphadenopathy, ESR and CRP are elevated. What is the best next step? So the key points here in this case, we have a fever for more than 5 days. Number 1, we have bilateral conjunctivitis. Then we have changes in the mouth, which is number 2, swelling in both hands and feet, so we have number 3, and we have number 4, cervical lymphadenopathy. So we have 4 criteria plus 5 days of fever. This is a diagnosis of Kawasaki disease, plus ESR and CRP are elevated. So the best next step is to do IVIG, high dose of aspirin, and echocardiograph. This is a 5-year-old boy with purple spots on the buttock and lower legs for 2 days. The rash is non-blanchable, associated with mild abdominal pain, scrotal swelling. Labs showed elevated platelet level, and ESR also is elevated. What is the most likely diagnosis? The key points here, we have a non-blanchable rash, is a petechial rash, plus abdominal pain and scrotal swelling, and the platelet count is elevated, is not low. If it's low, we'll think about thrombocytopenic purpura, but here is elevated. So plus you have abdominal pain and scrotal swelling, and ESR is elevated as well. This is confirming the diagnosis of Henoch-Schönlein Purpura. It's a clinical diagnosis. There is no certain lab to diagnose this disease. We have here painful swollen knee joints, limited range of motion for 8 weeks. All other exams and labs are normal, including ESR and CRP. The most likely diagnosis is oligoarticular juvenile idiopathic arthritis. It's a clinical diagnosis, even with normal ESR and CRP. They are commonly normal in this case. So there is no certain lab to diagnose. It's a diagnosis of exclusion. We have here painful muscle associated with weakness and facial rash, and CK is elevated. So the most likely diagnosis is dermatomyositis. Rash is worse on sun exposure, joint pain, chest pain, fatigue, and anemia. The most likely diagnosis is systemic lupus erythematosus. Next step, to do ANA. If ANA is positive, confirm the diagnosis with anti-double strand DNA. This is a 4-year-old boy with bilateral leg pain at night, no pain in the morning, physical exam is normal, he is very active. The most likely diagnosis is growing pain. So bilateral, not just in one location. The pain is at night, not in the morning. Physical exam is normal. This is very classic growing pain. No investigations, just reassurance and pain medicine as needed. Recurrent painful oral ulcers for the last 2 years, deterioration of vision, and skin rash. This meets the criteria of Behcet disease. Remember, in cases of systemic lupus, the oral ulcers are usually painless. Here is painful, and here for a long time, for more than 1 year, as you see. Recurrent fever, abdominal pain, scrotal swelling, rash on both ankles, elevated ESR. In between the attacks, the child is normal. You believe this child is having familial Mediterranean fever. Parents ask for genetic testing. You order the test is negative. So what is the most likely diagnosis? It is familial Mediterranean fever. So it's a clinical diagnosis, and negative genetic test does not rule out the diagnosis of this illness. This is the end of this presentation. Thank you for listening.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This video is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.